Zoom screen. If you look at your Zoom screen in the right-hand corner, you'll see that you can enable your closed captions for a live transcription option. We ask during the event, your microphones will be muted and your cameras will be turned off. Questions will be fielded through the question box. So we ask that you put comments in the chat box, and please put your questions in the question box at the bottom of the screen. At the end of the event, we're going to be holding a raffle. So the raffle prize will be open to anyone who can collect their prize in the Newmarket area, or anyone who would like to pay their prize forward to a senior in our local community. You can add your name in the chat box, or you can direct message me, Susan Steels. Anyone who wishes to participate can be, I'm sorry. So you're going to be invited to share your experiences on social media. You can use the hashtag World Elder Abuse, WEAAD, and Rights Do Not Get Old. And I'll put that in the chat box as well. So we wish to acknowledge the committee who planned today's event. Anna Melfera, the Director of Care at Memories Plus Group and co-chair of the Prevention Elder Abuse Committee of York Region. Sandra Eason-Bruno, the Director of North Simcoe Muskoka Specialized Geriatric Services. Rayanne Rideout, the Director of Partnerships on Elder Abuse Prevention Ontario. Laura Proctor, our Central East Regional Rep with Elder Abuse Prevention Ontario. Linda Eind, our Program Coordinator, Caregiver Support and Community Partnerships with Community Home Assistance for Seniors, CHATS. Ruth Ann Lobb, our Long-Term Care Best Practice Lead and registered with the Registered Nurses Association of Ontario. Deborah Saywich, a founder and consultant with Age Friendly Communities, and myself, Susan Steels. I'm a social worker and I am the chair of the Prevention of Elder Abuse Committee of York Region's World Elder Abuse Awareness Day Planning Committee. We understand that during today's event, we may trigger some sensitive feelings within you, and we want to assure you that today is a safe space. We also ask you to not put things personal in the chat box that you wouldn't want shared with all participants. And at the end of the event, we'll be providing some resources for those who reach out and would like some follow-up information. To start today's event, I'd really love to welcome Deborah Saywich to open up with our land acknowledgement. Deborah resides in Richmond Hill. She's a member of the Wasaugasing First Nations on the beautiful shores of Georgian Bay. She recognizes that there are many pathways, our journey of life, for the young, older, adults, and everyone in between. It takes a village to support one another. Deborah believes in empowering people and the service and support to take proactive approach to managing their life care. Deborah is a founder of Age Friendly Communities and will be launched the end of this month in June. Deborah is a longstanding member of the Prevention of Elder Abuse Committee of York Region. Thank you, Deborah. Deborah, I think we need to unmute
my
you.
apologies there. Yes, thank you so much, Susan, for the introduction. Today we give thanks, our relationships with Mother Earth, all our relations that we have with each other. As we meet here today, we are in solidarity with the Indigenous peoples of Turtle Island. The Turtle Island Solidarity Journey is an act of reconciliation and solidarity between the Indigenous and non-Indigenous people on Turtle Island. We ask that you acknowledge the truths and recognize them. Listen to what is shared. Today, we would like to acknowledge that we are on the traditional territories of the Wendat, the Haudenosaunee, we would also like to acknowledge the land we are on at this meeting place, the Mississaugas of the Credit First Nation, and those of the First Nations of the Williams Treaty. We would like to thank them and all our Indigenous people for sharing this land with us. We would also like to thank the Chippewas of Georgina Island First Nation, who is our closest First Nation community, Miigwech. Enjoy your seminar.
Thank you, Deborah. At this point, we're going to start the panel presentation with a video that was produced by the Canadian Network for the Prevention of Elder Abuse Committee. It is a newly related video that's going to start a pan-Canadian conversation around what we can do to prevent elder abuse. We truly believe that we all have a role in changing the conversation and influencing change so that elder abuse stops. We are going to be developing a roadmap. Thank you.
If you are lucky, every morning you wake up one day older. Getting older is the journey we all share. But for too many older adults, love and support along the way are elusive. They live in isolation or in poverty, alone or mistreated, often by family members who may not recognize the impact of their actions as abuse or neglect. The COVID pandemic has shown a bright light on social changes we need to make as a country. People of all ages need affordable housing, good healthcare, healthy food, an income they can live on, and a safe, supportive community. So, the Canadian Network for the Prevention of Elder Abuse is working together with partners across the country on a pan-Canadian engagement strategy with a roadmap for individuals, organizations, communities, and governments to work together to end abuse and neglect of older adults. Together, we can create a society that values and respects people of all ages, now and for the generations to come. Change is possible. Everyone has a role to play. Preventing the abuse and neglect of older adults is a shared responsibility. So, visit us online to learn more. Watch for the launch of our strategy this fall, and join us on June 15th for World Elder Abuse Awareness Day.
Well, are you ready? Awesome. I am just so thrilled to see that 80 people have joined us today, and we're ready to have a great conversation. I'm really pleased to introduce to you our panelists. Sandra Easton Bruno, she's a registered nurse with almost 30 years experience. Sandra has a master's of nursing degree from the University of Toronto and holds certification in gerontological nursing from the Canadian Nurses Association. With a history as both a clinical nurse specialist in geriatrics, a board member of the Canadian Nurses Association, and a senior planner with the North Simcoe Muskoka LHIN, she's led systems change to continuously improve the health of older adults and caregivers. Since 2016, Sandra has worked with Waypoint Mental Health Center, where she is building and leading the North Simcoe Muskoka Specialized Geriatric Services Program. We have with us also Joanne Yancis. So Joanne is a technical business development specialist who worked across Canada and the United States for most of her career, and who has been the caregiver to her elderly parents for the past 19 years. Her mother has Alzheimer's, and she's moved into a nearby long-term care facility 2.5 years ago. Joanne's father resided at a nearby independent living retirement home for 3 years until his death in August 2020. Despite multiple health conditions with kidney disease, heart disease, skin cancer, and shingles in his eyes. Their long-term care, complex medical needs and evolving care provided experience across a broad spectrum of patient services, including home care, institutional care, and palliative care. Thank you, Joanne. I'd also like to introduce Graham Webb. Graham Webb is a lawyer. He was called to the bar in Ontario in 1985. Graham is the executive director of the Advocacy Centre for the Elderly in Toronto, a Toronto, Ontario legal aid clinic, where he was a staff lawyer, litigation lawyer from 1995 to 2016. He carried out civil, criminal, administrative litigation at all levels of courts and tribunals, including the Supreme Court of Canada. He is a co-author of Long-Term Care Facilities in Ontario, the Advocates Manual, and a former editor-in-chief of the Journal of Law and Social Policy. Graham has won an award from Ryerson University for his excellence in teaching gerontology. He was previously the chair of the National Elder Law of the Canadian Bar Association and an executive member of the Ontario Bar Association Elder Law Section. Graham is a distinguished fellow of the Canadian Centre of Elder Law Studies. Anna Melfera is a registered nurse and the director of Memories Plus Working Group, working closely with individuals living with cognitive and physical challenges, providing supportive care and resources to clients and their loved ones, as well as leading the Memories Plus group team in developing and implementation of effective strategies, programs, and services in home care and an adult day program. She has obtained her national recognition as a certified gerontological nurse through the Canadian Nursing Association and is a member of the Gerontological Nursing Association of Ontario and the Canadian Gerontological Nursing Association, and is the co-chair of the Prevention of Elder Abuse Committee of York Region, a member of the board of directors of our Provincial Nursing Association, and a member of the South Lake Ontario Health Team Healthcare Table. Today's panel will be moderated by Julian Morelli. Julian is a political communications business and policy strategist. His career path began in the construction business before moving into private sector to own and operate 2 restaurants. His political experience over 2 decades includes positions as the chief of staff for the former chair of Canada's Foreign Affairs Committee, director of communications for the Green Party of Canada, Director of Communications and Policy for the Congress of Aboriginal People, and Press Secretary for the Advisor to the Minister of Indian Affairs and Northern Development under the Liberal Party of Canada. He became a strong advocate for major reform in long-term care homes and combating ageism when his mother-in-law, Mary Lou, entered long-term care. He has served as an advisor to the Government of Ontario's COVID-19 pandemic planning and recovering working table, representing essential family caregivers. He is a member of the Ottawa Hospital's Patient and Family Advisory Council and board member of the chair of the fundraising committee for a not-for-profit charitable long-term care home located in Ottawa. And Julian is also a newly formed member of the National Standards Care Committee. So we welcome Julian, and in doing so, we welcome all of you here today to discuss openly important subjects that impact the lives of our loved one and that involves the lives of everyone here that we care about.
Thank you, Susan. Thanks, and for the kind words and the great introduction of the panelists. And they are a great group. You know, I had the opportunity to meet each panelist personally because I didn't know them. What I can say is what a group of learned, compassionate, kind, and committed individuals and professionals. I really want to thank the Prevention of Elder Abuse Committee of York Region for hosting this type of event because they are a lot of work. And your commitment. I also want to thank the participants, you out there listening to this, who joined in. Your commitment's obvious. You've taken time out, so it's pretty obvious how committed you are. And whether you're a healthcare worker, an advocate, or a family member, I believe you're here because you want to make things better for our elders so they can live a dignified life. Everyone deserves that, and everyone should expect that. Today, we're trying to get as many questions in as possible. So we're not doing all the talking, but you're asking the questions and we're really having a chat. As a moderator, I may slip in a question once in a while, maybe one. It's fair to assume that some of the conversation today will be about what happened in the past, why it happened, because we need to understand what we can do to fix it. But after I thought about this, I wanted to put some focus on what I call the day after. Day after means what happens when COVID ends, when we supposedly return to a new normal. What does that new normal look like? And what do we ensure that it never happens again? So with that, I want to start by welcoming our first panelist. Had 2 conversations with her, Sandra Easton Bruno, and I would like her to say a few words, and she has a lot to say, and we could go on for hours. Sandra?
Thanks, Julian. It's great to see a few of my team members on. Welcome to everybody, and it's a pleasure for me to be here. So I was asked to start this off a little bit by telling some of the North Simcoe Muskoka Specialized Geriatric Services story. Early in the pandemic, in the very early days, we had a really good sense of what was coming. And for any of us caring for older adults, we were significantly concerned. We saw programs and services shut down. We saw usual care providers being lost in the system because they were only allowed to work in one organization. So all of those people that were familiar with those older adults and caregivers sort of were lost in the system. We saw physical distancing, social isolation, and we really knew this was going to have an impact. And right around the same time, a random tweet came out from Nathan Stahl around a study that had been published in May 2020, a letter to the editor actually, around what was happening in France. And it was really interesting to read. They were trying to understand in France why some homes, some long-term care facilities were more impacted than others. And they looked at one study in particular, one home in particular, where there was 24 deaths in 140 residents in a 5-day period. And what they found was that those individuals didn't die of COVID. They actually died of hypovolemic shock, which means they weren't getting enough fluids. And the staff, they had huge absentee rates. And so you kind of knew that it wasn't necessarily COVID that was going to be the big problem. We recognized that it was going to be not just COVID, but all of the COVID restrictions and the impact and the change that was going to lead to the health and wellness, the impact on the health and wellness of our older adults. At the same time, we had the military report come out that really spoke to, those 5 worst hit hospitals or long-term care facilities in the province. And you saw stories that were heartbreaking as a result of all of the circumstances. Individuals, you saw increases in narcotics and benzos, which were used to kind of deal with the behaviors because there weren't enough staff, delays in caring for people that were soiled, patients or residents crying out, kind of going unanswered. And our team at the same time was also seeing increases in caregiver stress, increases in behaviors. We were hearing about increased requests for medical assistance in dying with some of our partners. We heard about individuals who were not going into the hospital because they were too afraid, or facilities who weren't sending residents into the hospitals because they were too afraid that they would bring COVID back. So we sort of came up with this concept of what was called confinement syndrome. Confinement disorder was referenced in the French study, but we realized it was kind of a constellation of symptoms that we were seeing. And if you look up confinement syndrome, there really isn't anything in the literature. What you hear is about solitary confinement. And when you think about the prison system, really a lot of what our older adults were experiencing was not entirely different, being so removed and so isolated. And so clinically, for any of us that deal with older adults, we certainly recognize that the consequences of that isolation and that reduction in activities were lending to lots of the stuff that we were seeing, not just in the military report, but what our team was seeing, what the media was speaking about, things like physical decline, acute illnesses that were preventable, chronic illnesses that were having exacerbations. People were ending up kind of more sick as a result of it, falls, reductions in mobility, caregiver stress. As a result of caregiver stress, sometimes increases in elder abuse, memory changes, all of those sorts of things. And so, we kind of set on a path, but the conversation today is so relevant because that's really where a lot of this stems from. And Julian, I'll pass it back to you.
Well, thank you, Sandra. I know we're going to get some questions and into a real good dialogue on some of this among all the panelists. I wanted to flip over to Joanne, and Joanne, she's a caregiver, so I have a bit of a real heart towards her on this one because that's how I got involved in this. And all caregivers are essential to the family care structure, and I think it's important to say that we all share different experiences. So, Joanne, over to you.
Thank you, Julian. It certainly is an interesting position being a caregiver, especially during these COVID times. I can say that. I'll start by saying that the impact of COVID on our family was profound and admittedly not as shocking as some of the media stories. Despite separate living arrangements that best suited the different needs of each of my parents, our pre-COVID routine of constant togetherness included mealtime reunions twice a week, every week, be it lunch at mom's long-term care home, or a barbecue at my house, or a country drive at a restaurant, or wine and knitting on the patio of the golf course while dad played 9 holes. And for an 89-year-old man with complex medical issues, I think that's quite an accomplishment. We were all inseparable. We were an inseparable trio, and it was a commitment that supported our changing reality while maintaining our closeness and providing comfort for the changes of the past few years. It also included daily visits to me, to mom by me, and daily phone calls to my dad by me. And needless to say, we had an everyday presence in each other's lives. So as you can imagine, COVID stopped all that, almost all of it, other than the phone calls to my dad daily. As both my parents were locked away in their respective living quarters without access to each other or to me. The resulting health and wellness impacts of restrictive confinement were undeniable. Depression, weight loss, anxiety, stress, insomnia, loneliness, frustration, fear. And this applied to all of us, myself included. And I'm sure many of us on this webinar today all know those feelings over the last year. The debate about physical well-being versus quality of life and mental health was unending. And the deterioration to their respective conditions worsened over time. And it was painful to see, and it still is. Dad's trip to emergency changed things for all of us. The irony of Dad's palliative status providing an opportunity for reunification and togetherness is not lost on me. The isolation that began in March ended in June for Dad and July for Mom and Dad, and lasted until August with his passing. The essential caregiver status that reopened the door to Mom in September. Thank you, Julian, for being a part of that. With lockdowns, the last one just occurred a couple of months ago and lasted 9 straight weeks, interrupted our daily visits, which luckily have resumed. COVID stole and continues to steal precious time from us at a time when the clock was and is ticking very loudly. While I feel blessed for all the little silver linings that made the past year and a half more bearable, I cannot help but wonder what could have been done differently, and equally important, who will speak for those that don't have family, because they're there and they deserve a voice. Thank you, Julian.
Thank you, Joanne. It hits home. Our next esteemed panelist is Graham Webb, and Graham is a lawyer, as we all know, and so we won't hold that against him. We actually will take him in with what we need now is a type of expertise that a committed individual like Graham has, and you'll see in his bio how committed he's been to this throughout his entire career. Go ahead, Graham. Thank you very much.
I'd like to say to Joanne and Susan and to everyone else who has lost a loved one or family member during this pandemic, how sad I am to know that. And it's not always as it's not always, as Sandra said, a death from COVID, just a death, a loss of a family member during the pandemic is traumatic enough in itself because we aren't able to gather as we normally would to share our grief and sorrow and celebrate the person's life. My own mother is 98 years old. She was 97 when the pandemic began. She's hoping to be 99 soon. And during the pandemic, she's been isolated, vaccinated. She's lived in a personal care home where they had outbreaks and deaths within the personal care homes. And she also fell and broke her hip and had hip replacement surgery, which profoundly affected her life. And during all of this, at one point, we were planning for her funeral, knowing that she might not be able to have a funeral at all. And so it's been difficult for everyone. At the Advocacy Center for the Elderly, we're a legal aid clinic. We serve low-income seniors, and we work on the front lines of elder abuse and long-term care every day, day in, day out. And what we've seen on the long-term care home front started with exposure of the failures of infection prevention and control within many retirement homes and long-term care homes. Not all homes. Many homes had no outbreaks at all. But there were many other homes that had let's say, lax procedures that were undetected, unknown to the general public and to the residents, that became apparent when there were widespread infections and deaths. One of the many problems we heard about and helped try to address is that some homes would not transfer long-term care home residents to hospital, when hospital care might have assisted, even saved the person's life. And that is simply unconscionable and intolerable, that if you're a resident of a long-term care home, that you should not have available hospital care for COVID, for a hip replacement, for any medical care when you need it. We also witnessed the issue of confinement of long-term care home residents and retirement home residents. There is a process under Ontario law for a um, uh, um, chief public health officer, a medical officer of health, to issue an order under Ontario law confining certain people or certain classes of people to a space based on their medical condition. And when a confinement order is made, there's a process for appealing or reviewing that order. That did take place in rare circumstance in isolated parts of Ontario. But instead, what we also saw was the wholesale confinement of more than 70,000 long-term care home residents as a group, where the residents would see their caregivers, the PSWs, go across the street to No Frills to pick up some lunch or go outside to do things, where the long-term care home residents themselves were confined, if not to their rooms, then to the facility. Some who were smokers were allowed to go outside to smoke, and some who were not smokers took up smoking so they could have a breath of fresh air. We saw restrictions of visitors so that families and loved ones were not allowed access to their friends and family who were residents. We've seen issues over vaccines and concern by long-term care home residents that even though the residents themselves are almost universally vaccinated, there are some exceptions, that they have no knowledge of the extent of vaccination among staff and whether staff who are giving them care services are themselves vaccinated. The effect of the confinement is not limited to long-term care homes and retirement homes. Older adults living at home have had difficulty getting home care because of the stress on the system and the chronic problems that have been associated with healthcare in Ontario. When it was placed under stress, there weren't enough workers because they were sick or otherwise deployed. When they did come, there was a problem with inadequate PPE to protect the persons and the workers in their own homes, and also the transmission of COVID from one person's home to another person's home, the vector of transmission being the home care worker. We've also seen financial abuse. Older adults have been isolated from going to the bank, from doing their shopping, from their last line of defense, which is their family physician. Now, if you want to see your family physician, you probably do so by telephone or by video call, which is beyond the scope of many older adults. And older adults were forced really to do more and more online through the internet in areas that they were not at all comfortable or able to protect themselves. And we've seen massive frauds committed on older adults who were forced into the situation of dealing in a virtual world when they would rather have dealt with a personal world as they had done all their lives. I know there's much more and others will have more to share. Thank you.
Wow, that was insightful. A lot of things that weren't even known, I think, you're bringing to light. And thank you very much, Graham, for that. Thank you very much. And Anna. Anna is a rock star in my view. I've gotten to know her as well, and is committed. And again, it's a pleasure to get to know you, Anna. And I know you've got plenty to share as well. Thank you.
Thank you, Julian. And it's been, I'm humbled in meeting you as well. Thank you. So as mentioned, Memories Plus Group provides in-home support services, as well as stimulating and engaging programs in a supervised adult day program environment. Unfortunately, in March 2020 till September 2020, our adult day program, we had to close due to the public health and ministry health guidelines and mandates and keeping everyone safe during COVID. During this time, our in-home care service did continue throughout the pandemic. As Sandra had mentioned, and also Graham, during this time, there was staffing issues across all the healthcare sectors that were noted. Regular nurses and PSWs that clients were used to seeing perhaps weren't visiting any longer. The staff were only able to work for one long-term care facility, so that stopped the opportunity of them working in long-term and in community, or vice versa. Some of the community supports that were in person became virtual. And like Graham had mentioned, that this was a very difficult change and transition for many of our older adults, navigating this technology. Also hearing issues, for those that are hearing impaired, not being able to lip read was another big issue, just over the phone or with PPE. So we were definitely dealing with a lot of changes. Home care agencies, such as ourselves, we were no longer able to go in and provide the one-on-one supports that were, that were needed for some of our clients in long-term care. There was a huge lack of continuity in care because of the changes and supports in the community. Also, a lot of family members, due to the restrictions, were now not visiting, and this was causing a great deal of caregiver burnout. There was a lot of decreased support in the community, unfortunately. Increase in responsive behaviors were starting to happen more. We had many family members and patients themselves that had a fear of going to merge. So there was definitely increase in symptoms happening, chronic conditions, exacerbations. We noticed an increase in requests for DNRs, which means do not resuscitate. We noticed an increase in palliative care caseload and requests for palliative care in home. People were afraid that their loved ones would pass away in hospital and possibly not be supported and have their family and loved ones around them during this difficult time, which was heartbreaking. There was definitely a need and an outreach for extra care and support. So we were very proud to be able to offer a lot of the support in the community. All of our care is nurse case managed. So we really put a real focus on proactive measures, following up with physicians and with community referrals and community partners when things were happening ASAP because of the fear of going into hospital. There was definitely, like Graham was mentioning, there was fear of not getting hands-on personal protective equipment. So, we were always constantly sourcing out PPE. We wanted families to be reassured that the staff were in full PPE, that they were doing screening. We wanted them to know that they had access to a nurse 24 hours a day for whatever support that they needed. As I mentioned, unfortunately, the day program closed during March and September. But when we started getting wind that we would be able to open again in August and September, we actually went out and visited all of our adult day client members. And we offered, during the time that the day program was closed, we offered virtual programs. But we did realize that they were great for most older adults, but very difficult for those that had cognitive impairments like dementia, just having basically thinking that they were going to be able to integrate into these programs virtually for half an hour was really not working. So that in person, that human touch was really missed. The spouses and their loved ones reported decrease in engagement. They actually were very grateful, and I just could see their smiles right now when we went out and did the visits, and when we provided them with the kits, the stimulating kits for them to have something to do at home. They were just overwhelmed to see people in person. They expressed that the risk social isolation and the deterioration that was happening, like weight loss and decrease in cognition, decrease in their activities of daily living and engagements, and just in simple conversation, they felt that this was way worse than the fear of them coming out to the program and contracting COVID itself. So I must say this motivated me so much and motivated our team into taking and positive actions and working with public health and getting ready to reopen the day program. So unfortunately, to my surprise, there was no specific guidelines in reopening adult day programs. I was pulling from daycare centers and schools, but nothing, no specific guidelines for adult day programs that were there available from public health. So many consultation, phone calls, emails, research. Basically, we were able to put together a reopening guide, and I can just remember it now. It was the day before we were opening that the public health came up with the adult day program guidelines of reopening. And I remember running to our executive director and saying, here it is, it's here. And guess what? We nailed it. So I was just so proud that, you know, we basically followed through with what the guidelines were the day before we were ready to reopen. So everything from basically screening, giving them a laminated sheet, telling them, you know, make sure you complete the screening protocols, don't come in if you have symptoms. We gave everyone a clean mask when they were coming in at every visit, frequent hand hygiene and hand sanitation, and logging all the data. We rearranged the whole adult day program to enforce physical distancing. Of course, we had to reduce our numbers, but still we're able to open with decreased numbers. Our staff, phenomenal. You know, we had some great laughs, but we had some cries. It was a lot of work getting everything up and running and still running. The frequent disinfecting of the common surfaces, you know, the HEPA filter, the defoggers, all of that. But I must say all of that was so worth it and more, because when we did go out to meet all the families during our visit, that we did before reopening, it was just overwhelming to see how much trust they had in us, and how grateful that we were, you know, going to be reopening. Happy to say that to this date, we've had no positive COVID cases at our day program whatsoever. So I guess it is possible.
Well, wow. Thank you. And thank you to all the panelists. So we're going to enter a new stage now, which is we're going to open up the conversation. And I think I want to start with something that a theme around the increase in DNR. And also, I believe it was Sandra that spoke about there was an increase in DNR, and there was the idea that people just didn't want to live anymore. And I'd like to just focus on that. I know, Sandra, you brought it up, and I know that was an important element that you spoke to me about. And I'd like to have Anna just expand on it as more. And this does have a legal implication, and it also has a caregiver one. So we'll just let everybody chat a little bit about this. The will to live.
Yeah, so I'm happy to start. You know, if we think about older adults, think about any of us, we all have a meaning and a purpose, and those that surround us help us define that meaning and that purpose. And when you become entirely cut off from all of those people that you love and all of those people that are familiar to you, and sometimes in cases where your health may not be the best anyway, with no end point in sight, in the early days of the pandemic, it's not terribly surprising that we saw increases in older adults in terms of loneliness and that social isolation and the fear and the anxiety and the depression. In some cases, what our geriatric psychiatrists would call, you know, a major clinical depressions, that real sadness that you kind of can't move beyond. I think it's kind of par for the course when you're isolated from everybody that you love.
Well, when I look at that, Sandra, and medical assistance in dying increased. So, and then Anna, you mentioned that DNR's increased, that will to live. And with all of that, there's a legal, to me, a lot of people don't understand what needs to be done, how it does, what it implies. And Graham, I'd just like to get your thoughts on that and what people should be thinking about, or how, particularly caregivers, if they're the POA, what they should know, or possibly what they should consider if they're speaking out for or speaking for their loved one. Is there anything that you think you could bring to the table that helps people to know where to go to?
Well, when we're speaking of the will to live and increased requests for DNRs and medical assistance in dying, what really jumps out at me is the violations of the Residents' Bill of Rights that's found in the Long-Term Care Homes Act and the Retirement Homes Act. And, the fundamental principle of the Long-Term Care Homes Act is that the home is primarily the home of its residents and a place where the residents can live with dignity and in security, safety, and comfort, and have their physical, psychological, social, spiritual, and cultural needs met. And so, really, when we're speaking of loss of the will to live, I'm seeing a failure of observance of the residents' right to live in dignity and safety, and that's what most concerns me.
And so Anna, you spoke about DNRs. How does that, in your role as an advocate, a caregiver, actually a caregiver for caregivers, and I'll put it my way, and a professional, how does that conversation happen? And what did you notice? And what would you do as a front line to that, seeing a change in the will to live?
So I must say, definitely, it's emotional for sure. I like I mentioned, I think the fact of COVID and the fear of being in hospital and something happening in hospital and not being at home in their own familiar surroundings and environment and not having their loved ones around them had a really big impact on this decision making. I saw it mostly with folks that had a lot of comorbidities or limiting health illnesses that were ready to have these kind of discussions and conversations, or their power of attorneys or loved ones. So it is a difficult conversation to initiate, but I must say this was actually coming often from the patients, from the family who were requesting this.
From a caregiver perspective, thank you, Anna. That thought I think was separate depending on your experiences. And Joanne, I don't know if you have something you'd like to add to that, or what experiences that you may or may not have had. I know it's a sensitive area, but I mean, I know from our side we had certain conversations, but more on the will to live more than the will not to. So.
Yeah, we had both. I mean, my father had been, we knew that palliative care was in his future. We just never knew when. We had had multiple discussions about, when that time comes and what his alternatives would be. And his answer to me was always, let's let nature take its course when that time comes. I don't want to be on life support machines, and I don't want a very poor quality of life. So I kind of knew some of those answers, and the timing when it hit, you're never ready for it when it really happens, even though you think you might be. And, we're dealing with anxiety that had transpired over the previous year with their separation just because of their differing needs. And I still fail to understand why we have a system that can't support couples at different levels of care needs, and why after, 66 years of marriage, they have to be in totally separate facilities. And it's like, okay, so we'll just keep getting them together, right? That's my commitment. But then COVID hits, and then you realize that there's no plan for this, and there's no way to make this happen. And watching them both being stuck in their environment, I mean, I can say clearly my dad was climbing the walls, couldn't stand it, and his health conditions were getting worse. And I'm trying to understand what's happening with merely a phone call daily, and it's like that doesn't work. And then I watch my mom, who can't understand what's happening because of her Alzheimer's, can't have a conversation with you on the phone standing outside the window because she's telling you, I can't speak to you because Joanne's outside the window. So the irony of that, it's like, it's just a crazy situation. But their separation, and then it's compounded by the separation from the staff that they know, because everybody in the sector had to all of a sudden decide, I'm not working in these 3 places, I can only work in one place. So these intimate relationships with the residents all of a sudden are totally disrupted, on top of the family relationships that are disrupted, and then their own. So I think it was definitely a big impact.
Go ahead, Graham. Love to hear.
Julian, I'd just like to say how much what Anna and Joanne have had to say illustrates the difficult, if not impossible, position of the substitute decision makers, because substitute decision makers have no role in medical aid in dying because substitute consent cannot be given. But substitute decision makers are regularly called on to make substitute treatment decisions, including things like hospitalization, DNRs, you name it. And the principles of substitute decision making are that the decision maker must apply the last capable wish that would apply in the circumstance, where written wishes and oral wishes have equal weight, but the governing principle is that later wishes take precedence over earlier wishes. And so it doesn't matter what somebody has written in their advance directive or their living will. What matters is what they said to you yesterday. And when you can't communicate freely with the incapable person, how are you to know what their incapable wishes are? How are you to make decisions on their behalf without being able to obtain the information that you need to make those decisions?
Well, thank you. And I like the fact with the panelists, like if you feel like jumping in, that's great, and we keep it just fluid that way. But I really, I got a question about it. It's more of a legal one, and I'll go back to you for Graham for just to kind of close this off. How central is the any changes in LTC legislation, I guess is the way to frame it, to residents' Bill of Rights, is how the question was posed to me.
Well, the Residents' Bill of Rights is very good and strong legislation that unfortunately is not always observed. And so I think that when all is said and done, I think there will be changes to the Residents' Bill of Rights that may strengthen and enhance the Residents' Bill of Rights. But what's really important is to find ways to give care in a way that gives life to those rights, that really observes them. So it's less a task of legislative change on that particular front than it is to how we go about doing things.
Right. A question here coming in from the registered participants. It says confinement syndrome was well known to those with family members on secure units. We saw it for years. Now that the butterfly projects are showing almost complete remission of responsive behavior, Redstone Unit, Malton, can we bring an end to prison in LTC? And I think again is, if I'm looking at that and asking Graham as initially here, is there any rapid recourse mechanism in place or should be in place?
There are legislative changes that are not yet enforced that would give a right of review to confinement and long-term care, and those changes can't come soon enough. Confinement is a very long-standing issue, and it's been almost a gray area where confinement has been made at the discretion of long-term care administration and often at the request of family members. Sometimes confinement is absolutely necessary to ensure personal safety. Other times it's not. If I may digress to a brief story, I once represented a man who was a resident of the long-term care home under the financial guardianship of the public guardian and trustee. He was on a locked unit in an unair-conditioned home in August. It was sweltering in the home. I met with him to prepare for his consent and capacity board hearing, and I said to him, why didn't we go out to Wendy's down the street that's air conditioned, we can have lunch? And he said, am I allowed to? And I said, are you under any form of guardianship? He said, no. I said, well, we're allowed to go. So we went to the desk to sign him out. And the charge nurse and eventually the administrator didn't believe that he was allowed to leave the home until the administrator called the public guardian and trustee from his air-conditioned office in our presence and found out that indeed he is quite free to come and go from the home. And, I've had clients who have, quote, escaped from retirement homes in the middle of the night, not wanting to be there, and been apprehended to the police without any legal cause and been brought back to the home. And this is a long-standing problem that needs a lot of work.
Well, I've noticed even within our experiences that so many, I think this is how it works. I think these are your rights, but there doesn't seem to be any real consistency, and it causes trauma and confusion among caregivers, residents, even staff alike. So they're trying their best, but they don't know, and sometimes they're running simply on rumor or innuendo, something like that. But I want to ask this question to. I'm going to start with. I think on this one, I'm going to give it to Sandra. Ageism, and the question. I'll frame it like this: how deadly is it? And how do we really solve the problem and ensure that this never happens again if we agree or disagree that ageism exists? How do we what have you noticed? What have you seen in your professional career on this?
I'm going to see if I can navigate my way through that one, Julian. I think I want to pick up on the last one because the last conversation I think feeds very well into this. And, we're talking a lot about congregate settings, long-term care, retirement homes. This whole concept impacted all seniors, right? It impacted everybody, but it impacted all seniors, community, long-term care, retirement home, when you think about the concept of confinement syndrome. And the experience, as somebody had said in the chat, the concept of confinement in secure units, it's not new. None of this stuff is new. What's happened is that COVID has heightened our awareness of what was actually happening, and it's identified so many of the flaws in the system. And I think that when we talk ageism, I think we have to be a little bit careful. I think that there is a concept of intent in here as well. And I do think that the government, the organizations, as literally information was changing by the hour in the early days. You didn't know what was up, what was down, what was true, where we were going. I think people put best intentions forward to try and keep individuals safe. I think where we ran the risk is that it went on for too long. And I do think the whole piece around ageism and that concept of needing to protect, and we often do it in healthcare, well, they can't possibly go home because they're not safe. Well, you know what? It's not our decision to make. It's about giving the individual the information that they need to make informed choices, and then allowing them to make that informed choice. And so I think that's our biggest problem. I think that there is this level of control that still permeates our system, or still runs rampant in our system, where we know what's best. Guess what? You know what? In 20, 30 years, I am going to be in this boat. And I'm no different in 20, 30 years than I am today. And I'm going to want the right to make my own choices. Julie, when we were chatting this week, I always remember reading this article. It was called The Dignity of Risk and the Right to Failure by Gail Mitchell. And it's so true. We need to give people the dignity to live life at risk and the right to fail when that actually happens. But I think in this particular scenario, we were confounded, or we were complicated by the fact that people were trying to just keep everybody safe and reduce that curve and reduce the pressure on the system. And I think we just maybe push things a little too far.
See, and what maybe I'm going to frame it a different way. What happened in long-term care, and I don't want to stick on long-term care all through it, because this home care is critical, and it's beginning to get into the conversation and how critical that is and under resourced it is. But I look at pre-pandemic, we heard the horror stories. Now, I always thought in my mind, what if that happened if we had a national daycare program? Would that even be permitted to happen? So I go back to the question, was there, and anyone, just an opinion, I mean, do you think that ageism played a factor in the horror stories that came out of long-term care pre-pandemic? Because they were all there. Graham?
I did.
Oh
Anna?
yeah, absolutely, I do. I mean, and you can look at the issue of ageism through legal literature. For example, if someone dies due to an illegal act, the measure of damages diminishes with age. You know, the life of a child is worth much more than the life of an older adult, much less an older adult with a cognitive impairment or dementia, which we have seen be worth to the British Columbia Supreme Court as little as $2,500 of nuisance value.
Right.
And I think that the low priority that governments have placed on community-based long-term care, on institutional long-term care, on other supports for older adults, except when there's a crisis, is the witness to that. We've seen a previous Minister of Health, George Smitherman, break down in tears when confronted by Toronto Star reporters as to the abhorrent conditions in Ontario long-term care homes. And all of that is forgotten through subsequent election campaigns. And that falls not just on the politicians, it also falls on the voters who elect them.
Yeah.
The ones who prefer certain policy alternatives at the expense of others, that including proper funding of care for older adults.
Well, and Anna, I know you wanted to jump in on this. I, from a political, just at one point is, I come from a political world, and I can't make this a political issue because you'd have to blame everybody. And so I just want to go over to you for a brief few minutes or a minute or so and just see what you think of that, because I know you wanted to jump in.
My input was just going to be in regards to ageism. Sometimes I find it very difficult when the older adults are overlooked, where they seem to feel like they cannot make a decision, or that the power of attorney or substitute decision maker feels that they could abuse that right when the time's not right. So keeping that in mind, that if someone's not deemed incompetent or incapable, but just because they have a POA or a substitute decision maker and it's not the right time, if it's not invoked and it's not the right time to use it, just keeping in mind that the person is still there, that they're the center of the care, and that their voice needs to be heard. So I do encounter that, unfortunately, often, sometimes.
Yeah. Well, caregivers. Oh, go ahead, Graham. Sorry.
Julian, do I have time to just tell a very brief anecdote about ageism in the healthcare system?
I've got my clock on. Go ahead.
When I was a staff litigation lawyer for 21 years, I had a client, her name was Helen. She lived on Yonge Street, and she used to walk to my office until she was 98 years old. She lived to be almost 100. If you asked her how old she was, she wouldn't say her age. She'd tell you how old she was going to be. She was going to be 99. It turned out that Helen died of cancer, but while she was still in her apartment, she went to a hospital in downtown Toronto and complaining of pain in certain areas. And she asked me to visit her, and so I did. And I dressed up sort of like I am today, wearing a shirt and tie and blazer, and I could see her in the area. But I went to the nursing desk and said in a loud voice who I am, a staff litigation lawyer with the Advocacy Center for the Elderly, and who I'm here to see. And they brought me to her. And before long, her attending physician came over and wanted to pull me aside and speak to me privately in hushed tones about my client, who was fully mentally capable and 25 feet away. And I said to the doctor, and this was a geriatrician, a very well-known geriatrician. And I said to the doctor, my client is right here. Why don't we talk to her? Because she's her own decision maker and she needs to be part of the conversation. And so my client came into the conversation. She complained of things, and suddenly she complained of pain here, and the doctor ordered that test and so on. And eventually it was found that my client did have a cancer. She died about a year and a half later, not long before her 100th birthday. But even, like when she was fully mentally capable, living in the community, going to hospital, the expert caregiving staff, and these were experts, did not want to talk with her or to her. They want to talk about her. And that is endemic throughout the healthcare system.
I think that's
And by the way, through the legal system too. It happens with lawyers, it happens with police, it happens with financial professionals, it happens with all of us, and it should not.
I think that's the best I've ever heard it, because I've tried to frame it, and in different we experienced that. The first question we would get asked as caregivers was, "How old is Mary Lou?" Instead of saying, "Can you tell us a little bit about Mary Lou?" And that's the only way. But thank you very much. I want to hit on caregivers, their importance, but I also want to hit on home care and other alternatives, because we've heard the stories, but the fact is there's many more people living at home, 90-something%, I believe, that actually live at home in their older years. Sandra, could you just give me a bit of an overview of it, so that people out there know where to go, and if we get any questions coming in on home care, how do they ask what can be, where do they go? Because I think that's the avalanche of information now. People don't know where to go. And Anna, you may have something on that as well.
I think it continues to evolve and change as we're watching the Ontario health system change, but it still does remain home and community care, although their name has changed. I mean, part of their role is system navigation to try and help get individuals into that right lane of services that they actually need. They do assessments for long-term care. They help set up supports in the community. They help link people to respite services. So home and community care is a great resource in the system, and I'm sure Anna has more she can add as well.
Thank you.
Absolutely. The Central Health Line from Home and Community Care is a great website. So there, it's all of the services and support services in the community are available. There's also, you can always call 211 as well. They'll be able to link you depending on what area you're in also. There's a lot of education about navigating the healthcare system. I know I do, so I know Chats does a lot of that as well. So a lot of it is through going out, well, now mostly virtually, but definitely offering a lot of education on, what are the resources that are available to you? How can you find additional resources that you may be needing as well?
Well, thank you. I don't want to try to quickly go through a couple of themes. One of them is family caregivers, their importance in care, and not hugging, not just about hugging and all of that, what they actually bring to care, and from a clinician's point of view, what you saw, what you believe should be incorporated as part of the care team. Do you believe that? Do you believe they're experts? And also, I'd like to hear from everyone on this one, including Graham, on particularly on their rights. So we'll start with Joanne. I guess the question, Joanne, is how essential is your role, or how do you believe it to be?
I think my role was essential long before it was deemed essential caregiver. I think that my parents were unwilling to recognize the changes that were happening to both of their medical conditions as they were evolving. And I always say this in the support groups that I'm in, that you can never make the timing align exactly right with when is exactly the day we need to be in long-term care or in independent, retirement living. So you have this choice of being, a little bit too early, which nobody really wants, but it, beats the heck out of being a little bit too late. And I have seen people live the nightmare of being a little bit too late, not having a plan, not expecting things to change when they did. And then, the system is designed that when somebody becomes crisis and needs support, they are in the system, and you as a caregiver or you as a spouse are not part of that. And they immediately jump in, take action, make decisions for you, and you no longer have a choice, because the time to have made those decisions was when you were in control, and you've lost that control when your situation goes crisis. Okay. And that is heartbreaking. And I've seen that, and I didn't want to live that. And so being involved with them, taking them by the hand, walking them through things maybe a little early, and changing their situation before something happened has been a critical role of to me as a caregiver to help them make the changes they needed to make before that. And it's been stressful and it's been a long path, but I look in hindsight, I'm very grateful that some of those paths that we chose happened when they did.
Thank you. I'll just go quickly around the table because Anna, Sandra, Graham, you on the other side are interacting with caregivers. So can you just give us your insight into that? What you think?
Well, I think in long-term care homes, they rely on family members to provide care. They can't do it without them, and so they are essential caregivers. And in a community, um, I think that community-based long-term care is extremely important. The biggest problem that people have is gaining access to enough community-based care services. And I remember clearly one social worker I was working with on an issue of access to home care saying to me, Graham, I don't know what I have to do. Where I work, the only place that people can actually get allocated home care time is on discharge from hospital. Says, I'm thinking maybe I have to go rent a school bus, drive around and pick up all my clients and bring them to hospital so that they can get some home care services. And I think that what people need to know is that there are complaints mechanisms for each agency, and they are free to take advantage, to make complaints. People often are reticent to do so. Some people are not at all reticent to do so, but many people are. And that for certain types of complaints that have to do with the denial of service or the reduction of service, there is a statutory right of review to the Health Services Appeal and Review Board. And so if someone is denied home care or their home care is reduced, they may have ultimately an avenue for an independent tribunal to review that decision.
Thanks. Anna?
Yes, I definitely would say it's heartbreaking because most folks want to stay at home. That's where they want to be. But it's not possible without supports. So often they may have to reach out for additional supports privately. Not everyone could afford that, of course. So it's, especially during COVID, it's difficult when, there's family restrictions going on and agency restrictions going on, but you want to stay at home, but where's my help in order for me to stay integrated in my community? So that's very heartbreaking, definitely to see.
Sandra, I know you do a lot of guiding, setting, helping integrate when caregivers or a resident or someone living at home requires some assistance, but not sure what they need, or they're not getting or feeling they're getting the care they need, or their health care is declined, or their health status. How do you guide families, caregivers in that role?
So I think a lot of it is really linking, much like we've talked about. A lot of it's support, a lot of it's dealing with the caregiver stress, but it's very much linking to local resources. So, we've talked home and community care. In the chat box, there's been talk about the Alzheimer's Society. It's really about building the partnerships, linking them up. But Alzheimer's Society is great if you have dementia, but there's Parkinson's Association, there's Arthritis Association, and Anna hit the nail on the head when she said 211. 211 is a brilliant resource, and sometimes we have to go to it too to figure out what resources are out there. But I think in our case, it's as much sometimes about supporting the caregiver and the caregiver stress and the burden, and understanding what they're dealing with, and understanding where the pressure points are for them, to try and see if we can relieve those pressure points either on our own or by pulling in certain agencies. We talk a lot in the system about the need for more long-term care home beds, and there always will be a need for more long-term care home beds. But if we can actually get more resources and supports out in the community, there would be far more people actually able to stay at home in the community where they really want to be, instead of needing long-term care.
Good point. Good point. I'm going to take a couple of questions that are in here, and two of them are actually directed more to Graham, and I want to put them in one. There's a whole discussion about security cameras, home cameras, having a camera in your room, and you have a lot of confusion. Is your room for your elderly parent or your loved one considered a home? And is there any law that prevents you from not having a camera in a room, a security camera? The second one is a question that came in, says, what is the definition of abuse in long-term care? And if a caregiver complains about abuse, does the LTC home have to involve the police?
Well, I guess those are both kind of complicated questions. The
Yeah.
second one less complicated than the first.
Yeah.
Um, Under the, abuse has many different definitions, and I think the good people at EAPO and the Elder Abuse of York Region could really help us with the World Health Organization definitions. And I generally think of elder abuse as uh, uh, arising from a power differential, where a more powerful person takes advantage of a less powerful person, and the differential arises according to age. But when we're dealing particularly with the Long-Term Care Homes Act, abuse in respect of a resident means physical, sexual, emotional, verbal, or financial abuse. And within each of those categories, there's a detailed definition of what these different forms of abuse mean. For example, emotional abuse means any threatening, insulting, intimidating, or humiliating gestures, etc., that uh, um, are performed by someone other than a resident, or the same, um, that causes harm to the resident. Financial abuse means the misapprehension or misuse of a resident's money or property. Physical abuse means the use of physical force by anyone other than a resident that causes physical injury or pain, or administering or withholding a drug for an inappropriate purpose. That's physical abuse. Or the use of physical force by a resident that causes physical injury to another resident. Um, Sexual abuse, non-consensual touching. Verbal abuse means any form of verbal communication of a threatening or intimidating way that belittles or degrades the person, diminishes their sense of well-being, dignity, and self-worth. Or any kind of communication that causes fear in the person. And these are not exhaustive, but there's
Right.
many different definitions of abuse. And in Ontario, we have a zero tolerance policy for resident neglect and abuse. And so when abuse is reported, there is a legal obligation to report that to the appropriate law enforcement agency.
Well, on the question of cameras, I'm not sure if we touched just real
No, I haven't
briefly
touched on cameras
Yeah.
because they're completely different questions.
Yeah.
And with cameras, the first thing I think in long-term care is to remember that the long-term care home is primarily the home of its residents. And long-term care homes are very complicated places. They're very busy places, but they have at least three separate things going on all at the same time. One thing that's going on is it's a place of work. It's where people come to work to do their job every day, day in, day out, in shifts, 24/7. It's also a place of business because there is a licensee, and whether the licensee is a for-profit corporation, a municipality, a charity, or it could be a for-profit corporation managing a facility on behalf of a charity or a nonprofit corporation. It is a place of business for the employer and the licensee. But the third thing that's going on at the same time is it's someone's home, and that's the overriding factor.
Right.
And so, long story short, long-term care homes are able to place cameras in public areas where there's no reasonable expectation of privacy. So they can place cameras in the hallways and in the dining rooms. They are not usually able to record audio with this video because in Canada, you cannot surreptitiously record the audio of two people, neither of whom know they're being recorded.
Right.
You can, so anyone can record their conversations with another person as long as at least one of the persons being recorded is aware and consents to the recording. But if you have no way of knowing whether the people you're
Yeah.
visually recording know they're being audio recorded, you can't audio record them.
Okay.
Now we come to the home. Would you expect that someone could plant a video camera in your home? Probably not. I don't think you would. I had an unfortunate case many years ago, well, not so long, but I represented a 101-year-old woman uh, who had a difficulty with her granddaughter, who was her attorney for property. And one of the things the granddaughter had done was to tap her telephone line to record all her phone calls. And I took the opinion that this is against the law because my client had not known she was being recorded, nor were the people that she was speaking with other than her granddaughter. A lawyer on another side, who's now been appointed as a Superior Court judge, took the opposite view that an attorney for property and personal care has the legal right to eavesdrop on their clients' um, conversations. I disagree with that position. I think the person has a right to privacy. And so in the person's room, you cannot non-consensually install a video camera, and you might not be able to you cannot non-consensually install an audio recording. And there's issues over the boundaries of these.
Okay, thank you. I'm going to take it over to what Sandra and I talked about. You know, what does it look like? And I'll start with you, Sandra. What does it look like? I mean, we've talked about the past, the stories, what happened. But what do you think we can do better, and what do we need to do better? That's more important, and what so that no one forgets this. Because as I said to a couple people, everybody wants to go barbecue. They want to forget about what's happened, and if there is a new normal, a lot of people are afraid that we're just going to forget about all the things we've learned and what we need to do. So I'll start with you, and we've got about 6-7 minutes to go around, and I think that'll be a good question.
So let me start by laying out some stats. So the impact of COVID-19 in Canada at July the 11th, older adults aged 60 plus accounted for 17.3% of cases, 64% of hospitalizations, 60.1% of ICU admissions, and 94.5% of deaths, the majority of which were in long-term care. But again, this goes back to it affected all older adults. It affected all of us. It affected all older adults. So for me, I think there's kind of 3 layers we need to think about. There is the layer tied to the individuals themselves. These older adults have deteriorated, many of them functionally, cognitively, whether you are 60 or whether you are 90. And so how do we support them in getting back to some sort of better level of health and well-being? And the timing is brilliant with it being headed into summer, we can get out more, but how do we sort of re-engage that population? The second, to me, is about relationships. We've burnt a lot of relationships between caregivers, older adults, and organizations, providers, the system, the government, that we need to think about. And how do we start building those bridges again? There were a lot of facilities that did a brilliant job amid this, but there were many where there were challenges, right? And that's burnt bridges. Right. And then really at a system level, how do we change policy? Okay. So through long-term care stuff. So I think we need to think at a multi-level kind of approach.
So really briefly, Anna, what do you want to see? What are you afraid of not happening? Maybe is a better way of putting it.
I echo Sandra. She did a great job covering that. Thank you. But if there's one thing I can definitely add is bring them to the table. The older adults, the families, include them. Let's not forget about them. Let's hear their voice. Let's hear what they want. And let's not make all the decisions without them being part of the decision making.
Thank you, Anna. And Joanne, very quickly from a caregiver perspective, what do you want to see?
I want to see policy change. I want to see consideration of the rights of couples to grow old together and be together and have their needs supported, be it in the community or in a quasi-institutional community environment, whatever that looks like. And I want to see a voice that represents the people that are what I call state of the wards, that don't have family which is, probably 50% of the people that I see over at my mom's long-term care home have no visitors, have, as far as I know, no voice, and they're getting lost, and they deserve better. They deserve attention, that they deserve to be heard.
And Graham, same thing, real briefly. And what do you want? What do you want to see?
I think we need a paradigm shift in the thoughts and the thinking of the general public to really first and foremost recognize the humanity and the personhood of older adults, whether they're living at home, in hospital, or in long-term care, or retirement, or home, or anywhere else. And secondly, within that, we need also to greater understand and respect the work that people like Joanne and Anna and Sandra and hundreds of thousands of others do in providing for and arranging for care for older adults. We need to get past the point of warehousing older adults, putting them out of sight and out of mind, and just hiving them off to a place not to be seen or heard from. We need to make them part of our lives, part of our society, and to recognize the value of the work that's done to support the lives of older adults.
Well, thank you. And I'm going to ask you this one question that's a yes or no. Really, it's really that. I think it'll speak to a lot of things. And I'll start with Sandra. Did COVID increase your likelihood of a long-term trauma in your life? Will that be something that sticks to you?
Absolutely. Whole generation. Yep.
Anna?
Very much so. As a nurse for 20 years, I could say this will definitely stick with me forever.
Joanne?
No doubt. I've never been through anything like it, and I never want to go through anything like this again.
And then Graham, because you are the front to a lot of pretty terrific, horrific stories, I would imagine, and experiences. How about you? How is the impact?
It's life-changing. You never want to live. You never want to live it through the first time, nor again. And there have many nightmares, as to whether they would have to implement a triage protocol, as to whether we'd have a situation where emergency room physicians would have to decide who lives, who dies, who gets treatment, who doesn't, and we have a pretty good idea who would end up at the bottom of the heap.
Well, thank you. I really want to close it at this point to allow for some closing remarks. And I believe we're going to have closing remarks by Linda. And that would be great to hear. And we'll come back and we'll have some raffles, raffle prize. And then I'll just give you a little bit of a send off. And I guess there's a lot of links being posted in the chat. This recording will be available later. We could have gone on for hours. And I just thank everybody, the panelists. I think this was what I thought was a real conversation. And I thank you for that. So we'll go back.
Sorry, Julian, there was just one question directed to me in the chat.
Okay.
If I can just a quick answer. Did the government give you support or monies towards opening for the PPE? My answer to that is no. Thank you.
That was a quick short. Thank you. So Linda, we'll go over to you.
Okay, well, thank you. That was a great discussion, and I'm so happy to be here today and to be a part of PSER. I work with CHATS, Community and Home Assistance to Seniors. We are a not-for-profit organization. We offer many programs for seniors. We've had to flip on a dime, just as everyone else has, to move everything to the virtual world. But we're doing very well, and our priority at CHATS is to make sure that all of our seniors are cared for and that they are doing well. We are regularly in contact. We service York Region and South Simcoe. We have over 8,500 clients. And I am going to post some information for you so that you can take it away, but it will also be posted on the website. So don't feel like you have to write it down right away to keep the information. And I especially would like to thank Joanne for representing us today. She's an awesome caregiver. She's a fantastic advocate for seniors and caregivers. She also sits on the Ontario Health Team Advisory Committee, just to make sure that she's, keeps her finger there to help people out And I know for a fact when she goes into that facility, she's saying hi to all the seniors, not just her mom. She's doing her very best and we love her to death. So what I'm going to put up for you is just a little bit of information. It's very short. Hopefully you can see this. It's the resources. Prevention of elder abuse, of course, this is June. It's Seniors Month. It's Prevention of Elder Abuse Month. There's a lot of projects on the go right now. I'm a part of a fantastic project, Elder Abuse Prevention Across the Generations. We have an advisory council, and we're going to be putting together a lot of education and curriculum. And if you're interested in that, you can contact me separately or on the website. So let me get this going for you. So our panelist support agencies today, ACE, Advocacy Center for the Elderly, CHATS, Community and Home Assistance to Seniors, York and Simcoe, Memories Plus Group, also York and South Simcoe. We have North Simcoe Muskoka Specialized Geriatric Services, PSER, Prevention of Elder Abuse Committee of York Region. In addition, I've put a whole page of resources here for you. Anti-Fraud, Law Society, Legal Aid. If you don't remember 211, which is a great number, a great support, the Senior Safety Line is really important. You can call there for anything. Talk for Healing for Aboriginal Women, Crime Stoppers, South Simcoe Police, the Alliston OPP, York Regional Police, who we all work very well with, and they sit also on the committee, and the Victim Support Line. I just wanted to make sure that everyone was aware of the Elder Abuse Awareness Month and what all these agencies are doing. We all work very closely together. You can be in touch with any of us anytime you want if you have any questions. So thank you very much. I'm going to turn it over to Susan. She's going to do the raffle, and then Julian is going to do the close.
Well, it's prize time. Thank you, everyone. This was a wonderful, it was wonderful to hear all your questions and hear all the comments. Now, I took the liberty of just putting names down, even though you didn't say put me in for the prize. So we'll connect with you afterwards. But we're going to have how many, Anna?
I'm going to say 10.
Oh, we don't have 10 names. Okay.
Oh,
that's okay.
Should we just say everyone gets a prize then?
Yeah, I have Mary Ann, Colleen, Sanju, Constable Monica, Carolyn, Lisa, Andrea, Katie, Amber, Deborah, and Monica. So
I think that's 10 or more.
that's 11. We'll knock
We're
one
good.
off there.
No,
We're
that's
good.
okay. 11 is good. You all get a prize.
You're winners. And mhm.
So, so those prizes will be delivered by you, Susan?
For sure, all the way from New Brunswick.
Okay. So,
I have
listen,
partners.
well, I want to thank first the panelists once again, and all of them. And I've had actually the pleasure and the honor, I'll say, in my own right, to get to know each of you. Susan, I've gotten to know a bit more personally on some other areas, and she's remarkable. It's a super remarkable group of people. Graham, just unbelievably committed and there for everyone that needs it, and I'm sure his life is occupied. And Joanne, who I've got to know, got a part in my heart here, a caregiver. And I also, Anna, you're always special to me, and Sandra. But I think I'm going to answer that question I asked you. It impacted our lives. It will change the course of my life. Has my wife too. Never forget is my thing, but do something about it. And the question of what post-COVID looks like and never forget sticks out to me. And it's the question probably that we kind of went around and we addressed it is all I can recommend to everybody is vote for whomever you think is best. That would be my only suggestion. So thank you very much, and the participants today, thank you for listening, and I hope we did you well.
Thank you.
Thank you, everyone.